So efficacy will be better. Because oxygen, how it is stored, we don't know. So here we know that its efficacy will be better. So we can try all those things. How is the condition of Dr. Monica now? Flapping? Still not contracted? Is she okay? Okay. In spite of all the medical management, she is she is continuing to bleed and this thing. So now we'll go for conservative management, other conservative methods. We can go for this suction cannulas. This is SR cannula, Samarthraman cannula. This acts by compressing by suction action. It will approximate both the walls together. It's like a compression. How we do compression during cesarean section, like we hold the uterus and keep it like that. Similarly, it approximates both the walls. So to some extent, bleeding will get reduced. So we can insert it inside and connect it to the suction machine. And 10 minutes we can on the suction. It will get contracted, and then we can continue. 400 to 600 you should keep. Then 10 minutes you keep. Then half an hour you can off. Then you can go and do.
If your uterus is flappy, then you have to keep for 24 hours. Like you can
switch off
the suction. No, this uterus is already contracted. Why you want to continue suctioning continuously? There is no need to continue.
Yes. If it's contracted, you off it and see again relax. So that doesn't follow.
No. Once it is like if you switch off the suction machine, that small soft tissue will be suctioned inside. You should release after 15 to 20 minutes slowly. All the like cervical, vagina and everything you should remove. Then you should remove slowly.
Because the upper ones are big ones. So it may suck that pressure here wall also, here also everywhere. So once it's only 15 minutes to release, then slowly you should.
Then you can release digitally.
Patil was there, sir. I don't know who is the son, but this is Samarthraman. Then we have this Chhattisgarh cannula. This Chhattisgarh Itran balloon tamponade. You can prepare it in-house like by Bakri balloon is readily available, but it costs. But this is like a police catheter and condom we need, that's all. So you can puncture this valve, whatever is there, which is for inflation. Then tie that condom just above that, and wherever the condom fits in. Then inflate it. Inflate the condom with around 300 to 500 ml of normal saline. One advantage of this is this tip is open. Normally, previously, how we used to use to the condom, to the police catheter, the whole condom is to be tied and put it inside. So, but we used to not know how much of blood is getting collected inside. It doesn't mean that once you put inside, bleeding is not occurring. Sometimes still bleeding will be occurring from the sides if the space is there. So here we'll come to know if the bleeding is occurring. From here, how the urine comes out, like that blood will be coming out from this through this pipe. So if bleeding is still continuing, we know that it's not active. So we have to go for next method of treatment. Okay, so now we have commercially available, similar to this condom catheter is easily available. It costs around 1200, 1300 rupees. Like if you buy in large quantity from Pune, Burkes condom catheter is called as. But here again the tip is closed, so that collection will not be made out. Okay. So we can use any of this. So we can just try insert again same thing. Once the bleeding is controlled, you can keep them for 24 hours. Any of these. Once she is stable, don't unnecessarily, like how we keep a vaginal pack for the cervical, vaginal tears and cervical tears, we keep a pack. Once she is stable, we don't remove that pack for 24 hours. So similarly, once she is stable, don't do anything for 24 hours. But in spite of if she is bleeding, continue to bleed, then we will go for other methods. 500 to 300 to 600 they give us a range, depending on the tone of the uterus. If it means big uterus, you need 600. Cavity small, we can put 300.
Can connect it to drip set?
No. It's another insert, put it, that's all. The condom catheter previously we used to connect it to the drip because it was not tight. The normal one used to leak out. Here it fits tightly. So once you insert 600 ml is distilled, you don't have to do anything. So we can share that in this number in the group so that everybody can. I don't know, we have just first time we have bought it. Madam has given a thesis to student. Let us see how is the outcome, then everybody can write because easily available and easy to do also. So if all these okay, simultaneously when you are doing all these things, massage should continue and vital should be checked. How is she, sir?
BP is 90% and pulse is around 120.
So then I think we need to go for surgical management. We have to arrange. Once she's not responding by now, we should have arranged for blood. And as Madam told, early FFP nowadays the rule is 1:1:1. Previously we used to give only blood, but nowadays whole blood is not available much. Like we have PCs available because fresh blood is not available. Whole blood is there also, it doesn't have platelets because we don't have fresh bloods. Fresh blood needs to be screened. So one PCV, one fresh blood, one platelet. 1:1:1. You can plan for the transfusion. So you arrange for the blood, call for help, and arrange the OT. Arrange the OT, inform senior, call Vidri madam. So we can connect the blood, start blood, and so meanwhile while resuscitating her only should shift her to the OT. When you are preparing that, you should not leave the patient. Somebody should be taking care of the patient, and what conservative measure you have started should continue. And meanwhile we'll start with we'll prepare the OT. So in OT, what all you can do is, we can first go for the Beach compression sutures. Then we will go for Heyman's compression sutures. You can also put Dr. Gunashila's global encephalage, where even horizontal stitches are put along with the vertical stitches. If she is still not responding to that, then we can go for stepwise devascularization of the blood supply of the uterus. Uterine artery ligation, everybody is I think well versed with uterine artery ligation. So whenever you are taking uterine artery ligation, you should make sure that you take through the musculature of the uterus, not on the vessel. 1 centimeter from the medial to the uterine artery vessel, you should puncture and come out of the posterior part. Then wherever there is a avascular area in the broad ligament, there you should come out and tie it. So you can do bilateral. If you are thinking that the lower segment, sometimes the lower segment is little flabby, or you are suspecting a traumatic PPH, like cervix is lacerated, or like she was handled case and all, then better to ligate the descending cervical branch also. Just if they are not responding, then you have to go for peripartum hysterectomy, subtotal or total, depending on the activity of the cervix. If it's a normal delivery, then usually total will be done. If it's a previous section, difficult to separate the bladder, then we have to go for subtotal hysterectomy. Whichever is fastest, we can go with that.
So descending cervical artery.
Normally uterine artery, actually supposed to fix it like this. Uterine artery comes from the interiliac artery. The one branch, the bigger branch will go here. One smaller branch will be going along the cervix. So below the usually uterine ligation, you take time around 1 to 2 centimeter. You go push the bladder down and tie one more at the same level.
But once you ligate
once
you ligate the uterus, automatically it will be get.
Usually it comes down.
There will be no blood supply to that descending cervical. So no need to
no, sir.
do it.
Usually what they say, sometimes they divide here only.
Divide here only.
Like what is well versed with. Now one more, the new drug is carbamazepine. I think everybody has heard about it.
Does it help in postpartum hemorrhage atonic PPH?
No sir, it is not used as a
It is
prophylactic.
only prophylactic is used. Preventive prevention of PPH.
We have still not studied about it.
That's
So only
what-
prophylactically it is being studied now. But whenever you are having PPH, you can just use it as an additional drug along with all the list of drugs what we are using, because we don't know what is going to work. We can't wait until one works, whether it works or not, then try the other one. So simultaneously we will go on giving all medicine.
So usually before we used to give methazine, then after 5 to 10 minutes it doesn't contract and retract. Repeat the methazine.
Prostatic.
Even after 10 to 15 minutes, there is no contraction. Give prostatin, intramyometric.
Yes. The intramyometrial prostatin can try. Now actually we
Then
have tried
doesn't stop,
intramyometrial.
go for systematic
carbamazepine.
devascularization, and then for the other things.
Contraindications for carbamazepine.
Carbamazepine as of now, I
No
think
contraindication as of now.
because oxytocin also doesn't have much contraindication. But presently we have to still evaluate the cardiac side effects of the carbamazepine, because it is more stronger and longer acting, and heart has got the oxytocin receptors. So it might have some listen, because we have seen that there is some tachycardia, little hypotension, angina, all those things are there with the carbamazepine use. So anyhow, we are doing a study on that cardiac side effects and troponin levels with the carbamazepine. So once the results are out, we will be able to tell more about it, whether it's very safe or equivalent to oxytocin. Only advantage compared to oxytocin presently is longer duration, and its efficacy is maintained from manufacturer to the user. There, if the cold chain is not maintained, we don't know whether it is efficacious or not. Here, we know that its efficacy is maintained, that's all. But otherwise, it is equal or little, maybe lower also to oxytocin. Oxytocin is still the standard drug of in prophylaxis and therapeutic.
Use of SR can during cesarean
During cesarean also, if you want to insert, even these all these uterine tamponade bolus, you can insert during cesarean also. You can insert from inside, push that catheter through the cervix. But only thing when you're suturing the uterus, make sure that you don't puncture the condom again, because everything will go waste. So you should be very careful when you're suturing the uterine incision. Same thing can be done for this also. You can insert it from the above and connect the suction canal from below and continue your suturing and massaging and oxytocin. It will act as the same thing. You can later on remove it after 24 hours. Both cesarean and normal delivery, all these can be used.
Make sure that patient is not in DIC by the time you shift to the OT.
So we
Should
did
be
not
clear.
tell about the tranexamic acid. We have studied use of tranexamic acid.
Patient is already in DIC, you are giving all the treatments. They will not respond.
Responding. So only we are telling nowadays, whenever we have PPH, we have to arrange for all, so that they don't go into DIC. We have to give FFP and so platelets. Previously what used to happen, when they are bleeding, we used to only give blood and we used to not give FFP and platelets. So they used to go to DIC. So now whenever they bleed, give all the three in equal proportion and use tranexamic acid also. Tranexamic acid, it's not useful for all low risk normal laboring patient prophylactically. But in high risk patients, we have seen that in PH patient, because we know that there is some already position problems. So we have done a study, we have found that it is helpful as prophylaxis in PH patients in normal labor. So 1 gram can be given easily without
PPH
much
patient
side
you
effects.
can give that.
Not low risk patient.
Tranexamic
Low risk
you
patient
can-
prophylactically tranexamic acid doesn't help.
Doesn't.
Like
In
how
PPH
oxytocin
you-
helps. In
PPH
PPH we have to give, because once bleeding starts, there will be a problem with the position problem. So this will prevent that. And in PH patient, whether it's normal delivery or cesarean section, up to 1 gram we can use it.
As a prophylactic.
As a prophylaxis also. Any other medication you want to discuss? I mean, other routine things everyone knows, so you don't have to discuss much about it.
Sure.